We think that long COVID is a new autoimmune syndrome, and autoimmune disease occur more frequently in women than men. You also have to understand that despite vaccination and boosters, people can still get SARS-CoV-2 infection. That means new episodes of COVID-19.
What was the starting point for this curiosity and interest in looking at long COVID manifestations?
Excellent question. So I opened one of the first neuro-COVID-19 clinic in Chicago, USA in May 2020, the beginning of the pandemic in the US. And we saw since then 2,800 patients in the clinic who have neurologic manifestation of long COVID. These include brain fog, fatigue, headache, dizziness, blurred vision, problem with smell and taste, pins and needles, and others that really affect their quality of life. And in addition, some patients have problem with their cognitive function. I'm also a global neurologist, and I've been collaborating with other neurologists in Zambia for more than 15 years on other projects. I had the opportunity to meet through the internet and by Zoom Dr. Akaze and Dr. Okubadejo from Lagos University Teaching Hospital through the Institute for Global Health that we have here at Northwestern. And we wanted both to understand whether neurologic manifestation of long COVID also exist in Nigeria and whether there are similarities or difference between those two populations.
How do you directly connect long COVID with these manifestations, considering the fact that there are probably several other issues that is happening in the daily lives of these individuals that could also be connected to this? And he mentioned that his diagnosis by isolation, removing other conditions to finally establish that direct diagnosis. Is that connection also the global standard?
Sure. So there is no precise definition of long COVID, as you know. It is it's a syndrome affecting multiple organ systems. So the brain, the lung, the heart, the gastrointestinal tract, and others, which persist for at least 3 months from acute COVID-19 onset, according to the WHO definition that we have chosen. And those symptoms are different than the natural evolution of a viral infection that occurs otherwise in most people who get COVID and then get over it and don't have any lingering symptoms. There is currently no single diagnostic criteria. There's no blood test to diagnose long COVID, but we are working on this in the lab, and we're also working in defining biomarkers that could be detected in the blood to understand better the evolution of long COVID.
I think that's an interesting focus, but for developing countries like India, or let's say low or medium income countries where there are lots of competing interests for minimally available resource, do you think would be the justification for prioritizing the long COVID interventions?
So we have noticed both in the US and also in Nigeria, as well as in other places where we're collaborating, including Colombia in Latin America and India, that long COVID manifestation in general affect disproportionately young and middle-aged people. Older people also, older than 65 years old, also may develop long COVID, but when this is the case, it's more rare and those manifestations are milder in older people. That means neurologic manifestation of long COVID principally affect young and middle-aged people who are in their prime and participate to most of the workforce and innovation in our society, both in the US and in Nigeria and in other countries. When those people are affected by severe brain fog, which is then linked with objective cognitive dysfunction that we can measure with standardized tests, and when they also have severe fatigue, really affect their quality of life, adversely affect their quality of life, as well as their ability to work. All right. It is estimated that nowadays 14 million people are affected by long COVID in the US. This and globally, it's been also estimated that it costs the global economy $1 trillion per year in decreased productivity. So these are problems that are significant, both in resource-rich and resource-limited setting. And we have seen also that there are available treatment, symptomatic treatment that work for those patients. For example, patients who have brain fog and cognitive dysfunction get treated with cognitive rehabilitation, which is like physical therapy for the brain. All right. And those patients feel that this is really helping us recover some of their function or at least deal with their deficit better. And some have been able to get back to work. This cognitive rehabilitation is somewhat similar to that given to patients with traumatic brain injury and post-concussion syndrome after a motor vehicle accident, for example. And so the hope would be that we can also give those people this type of therapy that will allow them to reinstate the workforce and regain the quality of life that they have lost because of long COVID.
So how would you describe the global prioritization of long COVID as a real crisis? And are you concerned that what is happening to long COVID in terms of prioritization is similar to what has always been the negligence of the mental health aspect of serious infectious diseases, for instance? Is until recently that we started talking, people in developing countries started talking about mental health in HIV infections. Now we are seeing something in long COVID. Do you see a similar connection, or how will you describe this?
Sure. Excellent question again. So what is the contribution to mental health in the manifestation of long COVID? We ask patients when they come to the clinic if they had anxiety and depression prior to getting COVID-19, and it is about the level of the general population. But once they come to the clinic, at least in the United States, about 70% of those have some degree of anxiety and depression. And we really need to take care of those issues in parallel to their physical health, because otherwise it is an impediment on their road to recovery. And so whether it is talking to a therapist, or seeing a psychiatrist and getting antidepressant or anti-anxiety medication, or being part of a support group like we have, there are many different possibilities that we can offer, and depending on the patients and their preferences. And this is a very important part also of their recovery.
So let's talk about the reality of actually helping people that have these neurologic manifestations of long COVID. There is mental health practitioners. There is a dear shortage of mental health practitioners. When I was reading about this paper and hearing you talking about potential interventions that they could benefit from, like this therapy that you mentioned, there is a dear shortage of professionals to actually oversee and administer these interventions. So what insights regarding the practicalities of the solutions that you are proposing, especially stemming from probably experience in Nigeria and other places where you are partnering, that you can share with me on how to actually help these people?
Certainly, another excellent question. In the US, we were first really deluged with the number of patients who wanted to see us. And after that, we started doing the research. In Nigeria and in other places, which are limited resources, as you said, there is no structure in place to care for those patients. Therefore, we're starting to do the research, which has been sponsored by the Institute for Global Health here at Northwestern, to show that first, these problems exist. And then the next step for in Nigeria at least, is to do another study showing that cognitive rehabilitation actually help those patients, like we are currently doing, for example, in Colombia, Latin America. And hopefully, after this research is completed and we show that the patients really can benefit, then we can justify for the health system in Colombia, in Nigeria, and elsewhere to really take this problem seriously and offer those therapies for the patients. Again, cognitive rehabilitation, really, it's not a medication. It's like physical therapy for the brain. It is also efficient in patients with post-concussive syndrome after traumatic brain injury. And there are many of those apparently in Lagos, Nigeria, who could also benefit from such intervention.
Then, okay, I'm curious to know as much as you can share insight with me about geographical uniqueness of the data that we are getting from these studies that you are doing in different parts of the world. What is peculiar that we can say to one region and another? And if you can mention give some insights on what is probably driving these peculiarities.
Sure. So we always differentiate between people who have been previously hospitalized with COVID-19 pneumonia and those who only had mild COVID-19 sore throat, cough that went away and then developed long COVID. We have seen that patients who had pneumonia were hospitalized usually are older and they also had more comorbidities. Sometimes they had to be intubated in the ICU. And sometimes they had permanent neurologic damage because of this acute severe illness. On the other hand, the non-hospitalized patients are always usually younger, 1 decade younger than those who are hospitalized, approximately. And they were previously healthy before COVID-19, but still developed those manifestations. We are currently gathering data from the US, Nigeria, Colombia, and now in the process of doing that with India, compare North and South America, Africa, and Asia.
Interesting. Do you potentially see the recommended interventions for these different regions also differing?
Certainly, there are differences in obviously culture towards access to care. There are also some local, sometimes violence regarding even requesting or seeking medical care for a certain condition, especially in places where people, as you say, have many other things to worry about because of other health condition, way of life, the economy, political consideration. And we need to educate those people in those areas that actually something can be done that can help them. And also there's nothing invasive with those therapies. Cognitive rehabilitation doesn't involve any specific medication or any intervention. These should be understood by the patient as a form of therapy that can actually really help their symptoms. This is done in face-to-face meeting with a speech and language pathologist, for example, but also done through exercise that can be performed at home in between sessions.
So how will you see a potential global guidance on the management of the neurologic manifestations of long COVID playing out? Or do you think it would be something that would be restricted to regional?
So we have published in 2022, I think, in the Neurotherapeutics, a publication about our current care for neurologic manifestation of long COVID, both in hospitalized patient with COVID pneumonia and non-hospitalized patient that we see in the clinic. I think that many of those ways of treating patients can be applied in other countries. Obviously, it depends. For different type of headaches, you may need different type of medication that may or may not be available in country, obviously. And also, we need to be aware of the fact, as you said, that some regions like Nigeria are endemic for other type of infectious diseases that need to be taken in consideration when prescribing specific intervention or treatment for the patients. So it's not going to be a one-size-fits-all between the US, Latin America, Africa, and Asia, but there will be some line of treatment that will be working for all, obviously, and also lines of investigation that we need to continue. If we collect data and, for example, blood samples from people from all those different geographic area, then we will be better able to understand really what's causing long COVID in certain places, which may be different to some extent to other populations.
From a timescale perspective, do you think there could still be, we're already using the term long COVID, but COVID alone was around still just 2 years ago when it became a full-time thing. Are you concerned that potentially probably 5 years down or 10 years down, we could probably still see a unique set of symptoms or conditions that would be different from long COVID, that would still necessitate the need to probably still regroup and redo these kinds of research all over again?
Sure. And in order to answer this question, I will have both a unique research tool, which is a crystal ball for $9.99 on Amazon Prime, where I can exactly see the future. All right. And so this is the same question that people were asking me in, January 2020. How long is it going to last, right? I already had that for 4 weeks. Now people say, how long is it going to last? I've already had that for 4 years. And so there are people who get better with time after weeks or months, but unfortunately, there are people who still don't recover after couple of years. Now we have 4 years maximum. You also have to understand that despite vaccination and boosters, people can still get SARS-CoV-2 infection. That means new episodes of COVID-19. And we have seen that some people who had 7 infections, documented infection, may have picked up long COVID after the 3rd or 4th infection, right? We understand that there's probably a predisposition to develop long COVID, especially in our clinic. We see that 2/3 of the patients are women. We think that long COVID is a new autoimmune syndrome, and autoimmune disease occur more frequently in women than men. But some people will develop long COVID after repeated infection with COVID-19. I think we're there for the long run, since it doesn't seem that this disease is going to be eradicated anytime soon. We can only continue to take yearly booster shots to prevent severe manifestation of COVID-19, but those, unfortunately, don't prevent or cure long COVID.
Coming to a positive side now, when we talk about these issues, especially for Nigeria and other countries that may be already overwhelmed, back to where we started from, what do you consider as a potentially unique positioning that you think these countries can tap into to still be able to make some progress in helping their citizens that may be dealing with long COVID?
All right. So, the issue also is diagnosis, right? And I understand, here in the US, people can still do rapid antigen testing at home that they can buy at the pharmacy and still get diagnosed with with COVID-19. In Nigeria, the initial governmental campaign of diagnostic, I think, are over. And people who come down with a viral syndrome don't necessarily get tested, right? Or don't have the ability even to get tested. So I think it would be important to still have a correct diagnosis, since this is not going to go away, right? It is true that there are other infectious diseases going on in Nigeria, but the ability to diagnose new cases of COVID-19, I think, are going to be important, especially since the virus constantly mutates and different variants may evolve, and those different variants may have different manifestations, both acute and chronic.
What is the timeline for this bigger study that is going on, considering the uncertainty of the duration of long COVID itself?
Sure. I mean, we started doing research in April 2020. We didn't know how long that was going to be, you see. We still see about 60 new patients a month. Our clinic is still booked about 6 months in advance. And as far as we're concerned here, there is no end in sight, right? And so we've been privileged to collaborate with excellent academic physician like we have in Nigeria with Dr. Akasi, Dr. Okubadejo and colleagues, the same as in Colombia and in India. And we will be there for the long run, as long as it is needed.
Thank you. Thank you very much for speaking to me. Any last remarks?
I'm very grateful to you, Paul, for interviewing us, and also our Nigerian colleagues. It's important that the Nigerian population knows about this study, knows that this is a real problem, and that they are a solution that can be given to most of those symptoms. And we hope that this is going to help the quality of life of a lot of people in Nigeria, and also participate to the training of the next generation of doctors, nurses, and providers. Many medical students have participated to our research, and we're very grateful for that.